right, back in the pod.
All right.
With the maestro of preventing heart attack and stroke, my dear mentor, Bill Blanchette, who I share with patients often, has taught me everything I know about really feeling confident about avoiding events, heart attack and stroke. And you've often complimented the naturopaths on our ability to track and treat inflammation, the underlying root of all cardiac phenomenon, or the majority of cardiac phenomenon. And you went to bat for us when we were looking for registration in 2013, and we really appreciate that.
Was a while back, but yes.
Yeah, a while back, but you know, I said, okay, I understand inflammation, but you understand a cardiac report card better than anybody else, and that's where you introduced me to the EBCT scanner.
The reality is, you know, as physicians, we're not going to stop all disease. Mm-hmm. Disease will still happen. None of us are getting out of here alive.
Yep.
That's a certainty. But like I say, it's all in the timing.
Yep.
It's all in the timing. If we don't want to die young, we want to die young as late as possible. And so let's stay young, and let's stay on this planet as long as we can stay young. Mm-hmm. And there are things we can do that you've taught me, the things that I've found out and shared with you, that can make a real difference in keeping us young for a very, very long time. And whereas we're not going to stop the last heart attack, if we can stop the first 98 or 99 of them, that's pretty good. That's something we ought to be doing.
That's eradicating the number one killer of American men and women.
That's right. And it can be done, and it should be done.
It should be done.
And it's not being done.
And I did Fraser Meadows Retirement Community, one of the Cadillac facilities that has independent living with transition to assisted living to memory care for 10 years. And I just went and spoke on cannabidiol to Balfour, just on healthy quality with quantity. Mm-hmm. And what was amazing at Fraser Meadows all those years is they were both financially fit, right? They had maybe bought a house in Chautauqua for $30,000, you know, 50 years ago, and sold it for $3 million, and they were able to afford that kind of facility. But even that upper educated, affluent population did not have access to an EBCT heart scan until guys like you brought it to Boulder County and started educating the public. Yeah. We are 100 years in on heart attack and stroke as still the number one killer. And a real quick rattle for those of you who listen to episode 11, more women die in this country than men of heart attack and stroke. They just start later. They're that 55 to 75-year-old. They die more of heart attack and stroke than all cancers combined. So add up your breast, your ovarian, your lung, your brain, all also real diseases, right? And men and women, the majority of them, they're 50% of them, their first sign of I have heart disease is a fatal heart attack or stroke. Right. So
let's go a step further. We're just coming out of this pandemic. We're not out of it. We're coming out of it. And this pandemic has been horrific. 1 million people have died from this pandemic during the last 2 years, 2+ years. That sounds terrible. 1.2 million people have died from heart disease. So in the last 2 years, more people have died from heart disease than from the pandemic. Yet how much press has heart disease gotten every day? You don't even hear about it.
Yeah.
It's like it doesn't even exist.
It is a silent ninja pandemic, right? It is literally just as big. And then there's intersect, right? We've been saying the virus, you know, and again, this is more of a semantics biochemical conversation, but it's not necessarily the virus, but the overzealous, nonsensical immune responses to the virus that burn down the lungs, clot the blood. So now you have just another source of inflammation with COVID to drive more heart attack and stroke.
Right, absolutely.
And many of those were a tipping point where the majority of COVID deaths were pre-existing conditions. So you have people with midsection weight making more interleukin-6 inflammatory weight. You have people who are low in vitamin D, which is a known immune-modulating anti-inflammatory, on and on and on, right? But it all comes back to, COVID's just another addition to the inflammatory insults that can tip you into fatal heart attack and stroke.
Right. And you know, COVID will be in the rearview mirror someday. Mm-hmm. We'll rehash it time and time again. What did we do right? What did we do wrong? And at the same time, we're going to let heart disease continue to reign the havoc that's reigned not only in death, but the number one cause of disability in this country. And it's like really? Let's do something about it. It can be done. We've been doing it. We can show you the data.
Yeah.
It's not that hard, and it's not expensive. It's very inexpensive.
So one of the things I cherish about you is you're a grinded out practicing physician. You never stopped reading. You never stopped practicing, right? And I don't know how doctors who are really grinding it balance personal life and family life and our own health and so on and so forth. But you have street cred, and you've done some publications. You've done some in-house studies. You taught me things like the MESA trial, multi-ethnic study on atherosclerosis. It is also African American History Month, and I want to touch on the Black community and why they're at higher risk for heart disease and what they need to know about genetics and just protecting things like vitamin D and hypertension, et cetera. But you taught me that study. You also taught me, hey, there's these new blood thinners, Eliquis, Pradaxa, Xarelto, but there's time you use the old blood thinners like Coumadin. You still would use as your blood thinner if you have a mechanical heart valve.
Right.
And everyone follows that in cardiology as the standard of care. Everyone saw that study, Coumadin for mechanical heart valve people, even though we know Coumadin is a vitamin K blocker and can come with a little bit of rob Peter to pay Paul baggage, but that's standard of care. How come cardiologists and the primary care community doesn't also adopt what we see in the tracking plaque data in large-scale clinical trials like the MESA study? Where do we go wrong on not changing and improving standard of care?
Where we went wrong is a long sociological study. You could write a book this thick on where we went wrong. But kind of consolidate into the issues. When I was in medical school 1,000 years ago, we were taught that coronary disease was a progressive disease that got worse and worse and worse and worse. And finally, when you finished off closing off the vessel, you had your heart attack. That was what we were taught. We were taught we have to chase down that obstruction and find it before that last blood cell can't pass through anymore and fix it with a bypass. Why do we know that? Because DeBakey told us. And DeBakey is Jesus Christ. Yeah, DeBakey told us this is the way it is. Therefore, this is the way it is. That said, that's the way it never is and never was. But that's what I was taught. It wasn't until in the maybe 2000s, maybe late 90s, that we learned that no, that doesn't happen. Plaque ruptures and the vessel fills with clot. And it's the clot that causes the heart attack. It's not the gradual progression of the plaque. And that was new and that was different. But we still thought, let's find those obstructions and fix the obstructions. It wasn't until about the Courage trial from 8 years ago that we found that finding those obstructions and fixing those obstructions does nothing to reduce heart attacks and does nothing to reduce coronary death, except in the circumstance of aborting an acute heart attack. So if you're having an acute heart attack, if I'm having an acute heart attack, heck yeah, find that vessel, open it up, restore blood to my heart, get my heart going. If, however, I simply am doing my executive physical and I fail the stress test and I see there's an obstruction, I put in the stent, I fix the obstruction, even if it's a very, very severe obstruction, even if it's a very, very severe obstruction in a very important vessel, fixing that obstruction based on 9 randomized prospective studies is associated with 0 reduction in heart attacks, 0 reduction in coronary death. The only studies we have showing any value is in people who have 3 or more vessels or left main vessels plus heart failure, plus a decrease in their ejection fraction. In that subset, there is a small improvement.
For a stent or for bypass?
Well, the data is on bypasses.
Yep.
The data is on bypasses.
Yep.
But in all the other studies, 9, we see no benefit in heart attacks, no benefit in coronary death, no benefit in all-cause mortality by fixing that. However, between when Dr. DeBakey said this is the problem, we need to fix it, and now we have built a $100 billion industry around finding and fixing obstruction. And so it's hard to convince cardiologists that the technology that they have learned, the technology that they're doing, the technology that has bought them their house in Vail, is a technology that's not adding much value to the patient. Yeah.
Wow. It is threatening to bankrupt Medicare, unfortunately. It is.
And the quote in Upton Sinclair from the 30s, it's hard to convince a man the value of a technology when his salary is dependent on his never understanding it. And that's what we're stuck with. The cardiovascular industry, from the statin industry that had 3 drugs with deca-billion-dollar sales, to the stenting industry that has billions and billions of sales, to all the cardiologists who are putting in the stents who are making $100 billion a year, it's hard to tell them, stop. Let's not do this anymore. And honestly, it's not a conscious decision on their mind. Say, I'm going to continue doing something I know doesn't work because it makes me money. That's not what happens. It's a very subtle, pernicious thing that the cardiologist really wants to believe. It has to be making a difference. Look at this obstruction. I fix it. It's gone. It's fine.
So we were talking the other day on the phone where I said, hey, look, I accept that the holistic naturopathic wellness community has a feeling, and it feels right, and it sounds right.
Yeah.
So it must be right. Right. The problem is the conventional side of the aisle doesn't think they're vulnerable to the same thought process. So DeBakey goes, okay, this makes, and this is one of the slides. We'll review this with a page. So what Dr. Blanchette's saying here is, DeBakey said, just like the commercials I saw as a young kid on atherosclerosis, they showed the artery closes, and an event, and we have multiple studies that show 2/3 of fatal heart attacks in men were less than 50% clogged.
Right.
And you don't show clog on a nuclear treadmill test. You're still showing glowing blood in all 4 chambers of the heart, up to 70% clogged. Yeah. So 84% of men who have fatal heart attacks in literature pass their stress test, including President Clinton.
Yeah.
With flying colors, who had a positive calcium score.
The problem with Clinton is he had a very high calcium score. It looked terrible. He passed the stress test, so everyone said, okay, false positive calcium score.
Yep.
A lot of false positives in those calcium scores. There are no false positive calcium scores. There's calcified plaque in the vessels, and there's something called intimal calcinosis of Machiberg, which is rare. You have to have with diabetes and probably a little renal failure and stuff like that. It exists, but 99.99%
What if the EBCT
plaque.
scanner or the Siemens dual source 256 machine was given LSD? Could it hallucinate seeing calcified plaque? Is that, I mean, this is where I get, like, how do you think a high quality validated image is hallucinating plaque? It is or it isn't.
It's there. The thing that it doesn't do is it doesn't show us obstruction. It shows the amount of plaque and the metabolic quality of that plaque. If the plaque is inflamed, you're going to be putting down calcium quickly. The plaque is mellow, you put down calcium slowly. If the plaque has already been calcified, there's no soft plaque, you don't put down any more plaque. So it does not show obstruction. When coronary calcium imaging first came out, when the EBT was first invented in 1980, 42 years ago, when it was first invented in 1980, 42 years ago, we thought, great. This will show us where the obstruction is. This is the wide end of the funnel into the cath lab. And then they found out there's not that much correlation between your calcium score and the presence of obstruction. However, there's a huge correlation between your calcium score and your risk for a heart attack. But we were saying we were conflating presence of obstruction with risk of heart attack, despite the fact that 86% of heart attacks occur in non-obstructive vessels. 86,
okay, yeah.
Well, 84% of men pass their stress test.
Yeah.
But 86% of heart attacks occur in vessels that were not obstructed before the plaque fractures. So basically, no one's kind of put that all together and said, wait a minute, what are we doing here? So the coronary calcium didn't direct interventions. Therefore, the interventional cardiologists weren't that interested in it. It wasn't a big deal for them. And then there were other cardiologists who had competing interests. The competing interests that were making them millions of dollars. So they pushed back against it. They said, you shouldn't, you can't, you're not going to be able to do this, and delayed the application of this technology for 20 some odd years, just by constantly pushing back against it while they were promoting their own mostly unproven technologies. And that's where the line between intellectual disagreements and criminality kind of exists.
Wow.
If I am a high-ranking official in a major academic institution and I knowingly push back on a technology that can save lives to promote my technology that makes me a bunch of money, how is that not a crime? And that has absolutely existed. That's not true for the vast majority of cardiologists. The vast majority of cardiologists are doing what they think is best from what they've been taught and from what they read in the journals. But they just miss out on the essence. How do we stop the heart attack? It's not how do we find and fix the obstruction. That's not what this is about. In a post-Courage world, Courage trial was the second big study that found that stenting did not prevent heart attacks. Since then, there have been many more, but Courage was the biggest. In a post-Courage world, the cardiologists still have not really gotten their head around. It's not about finding and fixing obstruction. It's about changing the physiology that puts plaque in your vessels. And once you stop putting that fresh plaque in the vessels, your risk of fracturing plaque, of rupturing plaque, drops exponentially. And once we stabilize the calcified plaque, meaning we've stopped putting fresh plaque, the incidence of heart attacks drops dramatically. And the incidence of coronary death drops dramatically.
So I want to hit the pause button, and for our listeners, just really give some pragmatic examples of what you just said, which is unreal. First thing I'm going to recommend is Dr. Blanchette introduced me to The Widowmaker, and that is a phenomenal film that is a little bit of follow the money, but it is so well done, and it was by an Irish billionaire who gets furious because he passes all the traditional screening for heart disease. He's a thin, lanky, tall, handsome guy with $1 billion in the bank. He looks the role. He looks amazing. He looks handsome. And he's got a calcium score of 900. He passed his treadmill stress test, his nuclear stress test, his echo, his EKG with flying colors. And they basically gave him the pat on the back, and that was all mostly at UCSF, if I remember that.
Actually, it was in Houston.
It was in Houston.
Houston, yeah.
And then one of the cardiologists says, hey, you're here. Why don't we do a heart scan? Correct?
Pretty much, yeah.
Yeah. And he gets upset about basically the BS in the methodology because he was a walking heart attack. Yeah. If you have a calcium score untreated above 300, we're worried about you if you're 100, but we feel a little more relaxed going to bed that night. If you're above 300 and this is the first time we've discovered it, it's a little bit of a fire drill where we're loading you up quickly with anti-inflammatories, and we'll talk more about that in a couple episodes. But the Widowmaker is a good primer for this. Yes. My father-in-law got his first heart scan at Front Range Imaging. He had a 100% clogged Widowmaker. He is 100% obstructed.
Right.
And his own body built collateral vessels. His own body made endogenous bypass, self-made bypass surgery, right? Dr. Blanchette was mentioning a couple studies. The Cabbage trial was the first one that really undermined bypass isn't always the way, correct? That was in the cardiologist community the first big.
Well, there's a lot of them. I don't know which is the first.
Yeah.
There's a lot of them.
Yeah.
The basically with very, very few exceptions, when you look at a study, whether it's bypass or whether it's stenting, the value of revascularization is in getting rid of the angina that you're having, but does very little, if anything, to reduce heart attacks or coronary death. So the quality of your life is being impaired by the angina. I walk up a flight of stairs, I can't catch my breath, and my chest is tight for 4 or 5 minutes. Yeah, that's a reasonable person to put in a stent. But even today, we're having patients get preoperative nuclear stress tests in the absence of symptoms, finding a little teeny tiny area of ischemia on the nuclear stress test. Zingo, they're going straight into the cath lab to look for a vessel to open up. In the absence, the complete absence of symptoms. And from the cardiologist perspective, this is an imperative. This is something we have to do.
Yep. And in our world, what the Courage did, so the Cabbage is one of many that says, hey, let's reevaluate bypass and revascularization, opening up. Like my father-in-law didn't get bypass.
Right.
That was 10 years ago.
Right.
Right. And again, he doesn't follow through on anything we say, and he's still in pass yet. Right. So But revascularization is this idea of popping open the vessel with a stent or running a grafted vessel around as a bypass, right? So you're getting around the traffic or you're opening up the traffic. And what you're saying is in over 9 major trials on stenting, treatment, non-surgical, did just as well or better than stenting. But what you're also saying, so the viewers know, is stenting does not prevent future heart attacks.
Right.
So you're leaving the hospital with a false sense of security where you don't have to go back to your Blanchette style medical doctor or your roots and branches naturopath to really find underlying causes of inflammation. But then you're also saying, hey, this whole thing isn't about the vessel closing. The majority of the time, it's about this feta cheese soft plaque breaking off and stroking the brain or stroking a coronary vessel and having an event.
It's the number of anecdotal stories I could share from the patient who had valve surgery in her 40s. And in her 40s had enough obstructive disease, they threw in a bypass as long as they were doing the valve. And I was talking to her about her risk. Her mother was a patient, she wasn't. And she said, I'm not worried about that. I had a prophylactic bypass. It's like, oh, you so missed it.
You had a donation to your surgeon's Vail condo fund.
That's right. You have had a horrible family history. You have premature coronary disease, and that bypass is doing you nothing.
Yep.
A little known statistic is that people who have obstructive disease, who have heart attacks, are more likely to survive their heart attack than people who did not have obstructive disease before their heart attack. Because as with your father-in-law, the obstructive disease promotes collateral circulation. And so that vessel can give up the ghost, and you're still getting blood to the distal coronary.
It was a slow and steady, which allowed some other construction to happen.
Exactly.
Whereas a quick rupture.
Quick rupture, yeah.
And again, I don't want you guys in the ambulance saying, Dr. D and Dr. B said I don't need a stent. Remember, there is a time
Absolutely
where you need a stent, and that is in an active heart attacking situation. Is the one time where, per the literature, you can really make sense of it. Now, again, you have to go the other way then. You have to go inflammation hunting, inflammation killing,
right,
and be working with a provider who is willing to order an EBCT or a dual source 256 slice Siemens or a $50 64 slice heart scan, but you want to be able to get one of the newer images if possible so that you can track your plaque.
Yeah.
So give us just a quick, what are the machines out there that have high enough resolution so that you can actually use it as a serial calcium scoring report card on an annual basis?
So when almost any CAT scan of today's generations, a 16-slice CAT scan that takes a half a second to create an image, you can do a calcium score on a 16-slice CAT scan. However, if you do another calcium score 5 minutes later, your result might be 35, 45% different than the first one. So I can tell you with reasonable quality whether or not you have plaque in your coronary vessels based on a 16-slice low-speed CAT scan. Now, a half a second scan acquisition used to be super high speed.
Right.
Now is low speed. The faster the scan acquisition, the more motion artifact is taken out of the picture. And so the first scanner that had fast acquisition was the electron beam tomography, which I say was developed in 1980.
Wow.
When it was out, it took a full second to rotate around on the fastest machines. Some of them took a minute to rotate around. And so you had a machine that could do it in a tenth of a second, capturing the heart without motion. That set the standard. Since then, the helical scanners have gotten faster and faster and faster, but still a 64-slice scanner, the typical 64-slice scanner from name of manufacturer, still takes a third of a second to rotate around the patient. And they can get the image in about a quarter of a second. But a quarter of a second is a quarter of the heart's beating. And so you are going to get some motion artifact. So if you get a heart scan on a 64-slice scanner, you can't legitimately repeat it the next year and expect to fine tune your
Track
treatment.
14% growth or less.
Yeah, you try to track 14% growth in a technology that might have a 35% scan-to-scan variability. So if you have a 64 slice scan, you can get another scan, but you have to wait at least 3 years, maybe 4 years to get another scan. If you get it on an EBT, we can get accurate results the next year. You had mentioned the Siemens dual source. The Siemens dual source is this genius thing that Siemens came up with, where they got their machine to rotate around in a quarter of a second, but they put 2 lines of detectors, 2 rows of detectors, so it only has to rotate halfway around. And when it comes to creating an image, you can create an image in 7/100ths of a second. So the Siemens dual source, we actually get something that is as good as or superior to the EBT in temporal resolution. Plus, since we're lining up, 126 slices at the same time, we get much better spatial resolution too. So this is actually the first time I can say there is a machine that works better than the EBT. Most people don't have it, but there's a machine that works better.
Yeah.
It's more expensive than 64 slice by a lot.
Yeah.
It's more expensive than the other competition. But if you're going to track plaque, if you're going to say, let's check your heart scan this year, and let's check it again as soon as we can to make sure what we're doing is working, you want to invest in the best machine to do that.
Yep.
It's just the number one killer in this country
Yep.
that can be stopped. Why wouldn't we invest in the best machine?
Absolutely.
And I'm not on Siemens staff.
No.
I get nothing for this plug.
Yeah.
But a Siemens dual source scanner is the thing that can be used instead of an EBT.
Yep.
If you can find an EBT, for great, you got what you need.
You can absolutely track your plaque.
Plaque. But with the Siemens dual source, you can also track your plaque.
Yep.
And that's the good news, because industry has basically put the EBT out of business.
Yeah.
The competing cardiologists have shut the EBT business down. It might survive. We'll see. But the chance of it not surviving exceeds the chance of it surviving.
Wow.
The Siemens dual source is going to be a future technology where we can follow plaque, we can track plaque, we can make a huge difference.
And the biggest thing about speed, if I have it correct, is that you're trying to catch how much calcium in between an actively beating heart.
That's right.
Right? And you're going to get a little bit of artifact if the machine's too slow. But if you can get the image, then you can say, I can get the same stable image next year.
That's right.
And say, this grew by 14% or less.
Right.
Which is going to prove the majority of premature heart attack and stroke are not going to happen.
Yeah, there's during the heartbeat, there's 2 points where the heart doesn't move much. One is at the end of systole, squeeze down, and one is at the end of diastole when the heart is filled back up with blood. If you have a scanner that's fast enough that you can catch it either at the end of systole or at the end of diastole, you can catch the heart without motion.
Yep.
It takes a really, really fast scan acquisition time. And a quarter of a second doesn't do it.
Yep.
Now, with most of the studies using 64 slice scanners, where they get reasonably good results, they beta block the patients. They put them on propranolol or metoprolol, slow their heart rates down to below 60. And so if you've had a heart scan on a machine that's not a Siemens dual source or an EBT, and they did not slow your heart rate down below 60, the scan-to-scan variability is beyond the 30 to 35% that we said it was. It could be substantially more.
Yep.
So any heart scan is better than a stick in the eye.
Yep.
But to get the full value out of a calcium score, to be able to follow it over time and see if your plaque is changing over time, is a hugely useful tool, monumentally useful tool.
Awesome. So just a couple of things. As a doctor, I work to be apolitical, unemotional, and not bring my personal baggage into people's healthcare decisions.
Hard to do.
Right?
Yeah.
That is our goal.
That's our
to
goal.
be the clean diagnosing machines. And what this brings up for me, that the EBT was created in 1980. And we have things with China, we have things with Russia, we have the pandemic, we have a really interesting world right now. In my opinion, what's kept America as the leader of the global economy in the world is innovation.
Right.
And you're just telling me we had an EBT in 1980 and we finally outcompeted it in 2021 because we undermined the development of our own technological discoveries.
Absolutely.
we are screwed. I'm just going to say that out loud. Like, and for the embarrassment of riches we have as a country, that we are not the best quality of life to go with quantity of life is really upsetting. Because when you take out heart attack and stroke as a number one killer of Americans, you go to Boulder Internal Medicine and you see 98-year-olds walking around everywhere talking about their year in the garden, and that should be, I feel, the standard of American healthcare, and a bragging point for come to this embarrassing riches of quality care that is also cost effective. So I want to ask you about some false prophets you've taught me about over the year for our listeners. Following lipids.
Yes, great.
So we have a room full of 100 people. I have a lipid panel on all of them. Does that tell me anything about who will heart attack or stroke in that room?
Nearly nothing, almost nothing. We have studies showing no correlation between lipids and coronary disease. We do have the Framingham study that showed a relatively small correlation between the group with the highest lipids and the group with the lowest lipids. The group with the highest lipids had an increase in coronary events. Not like they had all the heart attacks and these had none of the heart attacks. There was a little bit increase. There's also the Bogalusa heart study that shows no correlation between your cholesterol and presence
Which
of
was
plaque.
a study with 103,000 people admitted that had basically same LDLs.
No, that's a different study.
Yeah, which one was?
The Bogalusa heart study is similar to the Framingham.
Yep.
It's a prospective observational heart study in the city of Bogalusa, Louisiana. And that study, everybody who participated consented to a limited autopsy of their heart upon dying. So they killed in a car wreck, fell out of a tree, whatever. They'd look at the heart and say, do they have plaque or not? In the Bogalusa heart study, there was no correlation between high-density cholesterol, low-density cholesterol, and the presence of plaque in the coronaries. Small correlation with triglycerides. In Framingham, there was a small correlation with high density and low density and coronary events, no correlation with triglycerides. Just makes your brain hurt. Makes your brain hurt. The study that you're alluding to is in the Heart Journal.
Yes.
And it was 104,000 people presented with acute coronary syndrome. And they measured their LDL and their HDL cholesterols and found that the people who had heart attacks, compared to 64,000 people who were admitted for non-cardiac diagnosis with no history of coronary disease, the people without coronary disease had the exact same cholesterol as the people with coronary events. In fact, the LDL cholesterol was slightly better among the people who had coronary events than among the people admitted for non-cardiac diagnoses.
Say that again.
So in this study, the people of the 104,000 people presented with coronary events, their average LDL cholesterol was slightly better than the 64,000 people presenting with non-coronary diagnosis and no history of heart disease to these 500 reporting hospitals.
And for the listeners, that's a huge study, and I want to say it a different way. The people who were not having events had slightly higher LDL, quote unquote, but quote unquote bad cholesterol. Yeah. And I always get upset when people call LDL bad cholesterol because it carries vitamin K2. It is the shuttle for K2. So I say, how can you call the guy that taxi cabs K2 bad? Yeah. But the reason I wanted you to share that one is I looked it up the other day because I borrowed your slide deck to talk to the Colorado Association of Naturopathic Doctors about 5 years ago, and I still go back to that slide deck. It is so enlightening, and I went and read the actual study, and you know what the conclusion was? We have to lower their LDL more.
Yeah.
That was the conclusion of the study. Instead of the conclusion should be maybe a lipid panel is not a good biomarker for predicting who is going to heart attack and stroke in this room.
Well, you know, that gets to a good point. People will come in and we just do a little blood work. We check their cholesterol and it shows their cholesterol is high because their total cholesterol is 180 and now 170 is normal.
Right.
Or their LDL cholesterol is 102 and now 100 is normal. Yeah. Well, actually, if you look at the way we define normal with every other test, we get a large number of patients who are normal.
Yep.
We check that level, plot it on a bell-shaped curve, go 2 standard deviations from the mean, and that's normal. Well, if you do that with coronary disease, you'll find out that virtually all heart attacks occur in people with normal cholesterol. And so we keep redefining normal and pushing it down.
Wow.
So now, although by population dynamics, a cholesterol of 240 to 260 is normal, We now say you have to get below 107 to be normal, because if we push it down low enough, we'll finally have the majority of people with heart attacks having elevated cholesterol. But the majority of people without heart attacks will also have elevated cholesterol. So we've accomplished nothing with this.
And that, well, no, we have accomplished something very dark, and why that's totally unacceptable in my data-driven evaluation is you have people like you and I who critically think through the methods of that study and say that conclusion doesn't add up with the results, right? Mm-hmm. Good methodology. Okay, no, don't smash cholesterol lower. The conclusion is this is not a good biomarker. Yeah. And when you compare even the Framingham results compared to what you get off an EBCT, it's a joke. Yeah. It's a statistical joke. And then what do we get? I'm going to say three things and I'll let you riff on them. But the first is we get cookbook doctors who then bully patients into a statin, literally. And the scary thing is I do think they're well-intentioned most of the time, right? Because it's like a Pavlovian trained response. But I'll let you riff on what statins really get. We know statins drive the Women's Health Initiative of having higher type 2 diabetes in women who are on long-term statins. And then we just had a well-done study in the Journal of Nuclear Medicine. Gary first introduced me to it, and then you and I talked about it a little bit, that showed lipophilic statins, not hydrophilic and not non-statin takers, with mild cognitive impairment at 65 years old had an increased conversion to dementia on lipophilic statins. That's atorvastatin. That's Lipitor. That's the number one prescribed drug that, per what we've talked about, does a 17 to 24% reduction on the best day of heart attack and stroke. If you're lucky enough to get a reduction in your heart attack or stroke, it's all the sit in the corner drooling with diapers, in diapers, at 15 to 20K a month for Cadillac facilities, right? We're getting close to $200,000 a year, or you're on Medicare facility for $4,000 to $7,000 a month. Yeah. And that's where it gets, I don't have time for it anymore, because when you visit a senior who is on a lipophilic statin, and we have that, and we don't change standard of care, and then they don't have the quality of life to go with the quantity. They're sitting there. Maybe they get a little decrease in events, but their ticker keeps going and their brain craps out. And then you have all the finances and trauma and drama that the family has to deal with.
So here's, first off, statins do reduce heart attacks by a certain percentage. And in the best studies, they reduce heart attacks by 20 to 25%, and coronary death by 17 to 20%. And back in the heyday of statins, back in the 80s and 90s and early 2000s, the amount of marketing that statins got, the amount of push that statins got, was pretty remarkable. The thing we don't realize that when statins were first marketed, it was 10 years of selling statins before we had the first study showing a 20% reduction in coronary events.
Wow.
We prescribed statins for 10 years based on the fact that prescribing niacin and questran, cholestyramine, reduced cholesterol and reduced heart attacks. We assumed that since statins reduced cholesterol, it would reduce heart attacks even better than niacin, because it lowered cholesterol more effectively than niacin. And we get out, well, it wasn't as good as niacin, but we forgot about niacin because it's been 10 years since we've used niacin. Wow. So now we have a crop of doctors who've never seen niacin, and we're all celebrating the fact that we've got a 20% reduction. Well, where I went to school, 20% was an F. Even where I went to school, 20% was an F.
Even down Louisiana.
20% was an F. And so we're failing, and we're celebrating our failures.
Yeah.
We talked about why we're not doing serial coronary calcium as a metric for success. It's a huge metric for success. It's an incredibly powerful, validated metric for successful treatment versus determining unsuccessful treatment. During the heyday of statins, they found people with plaque. They put them on a statin and found out that statins did not stabilize the plaque. And so since statins don't stabilize the plaque, and since statins are the only tool that we've ever had and will ever have to treat coronary disease, there's no point in doing a serial heart scan, because we already know you need to be on a statin. We're not learning anything we didn't already know.
Wow.
That is a major blow against doing serial calcium, completely ignoring the fact that my lifestyle choices can affect my risk for a heart attack. what I choose to do, what I choose to eat, how I choose to exercise can dramatically affect my risk for
The
heart attack.
flossing I do before I go to bed, the dental visits I have, I finally listened to my spouse who told me as a thin, lanky person that I do weird stuff when I breathe.
Yeah.
Right.
Sleep apnea, big time.
So that is crazy, and it's such a shame that every med student doesn't have to come through Boulder Internal and look at your repeat calcium scores.
Yeah.
Because the stabilization of plaque is exquisite, and the prevention of heart attack and stroke is exquisite, and it needs to be in conventional and naturopathic medical schools, and it needs to be standard of care.
And at least let's have a debate about it.
At least,
yes. I'm ready to go toe-to-toe with any of the experts
Yeah.
who are here to tell me that statins are the only way to go, that LDL lowering is the only way to go. I'm ready to go with them.
Yep.
I don't get those invitations.
Yep.
No one actually wants to hear the other side.
Or that serial
story.
calcium scanning, tracking your plaque, is the most prosperous method at preventing heart attack and stroke ever discovered on this planet at this point in time. Maybe in 5 years we'll have some gene test and it'll be obsolete. I look forward to that. It is an easy, cost-effective, empowering, power-to-the-patient method to say, good job, we got to work a little harder. Good job, we got to work a little harder. I'm missing something as your doctor. Right. Let me drill down a little bit deeper and see if we can go inflammation hunting, inflammation killing. So we got a couple minutes left. Follow lipids. Tell me about HSCRP, high sensitivity C-reactive protein. As a good marker for general inflammation. We follow it in our Crohn's patients and all kinds of people to see how we're doing big picture. Can I trust HSCRP to tell me, am I winning the war on heart attack or stroke?
So CRP, not HS, but CRP is what we use to follow rheumatoid arthritis and Crohn's disease and other inflammatory disorders. HSCRP redefines the lower half of normal CRP. Normal CRP is up to 10. HSCRP looks between 1 and 5 and says if your level is between 1 and 5, the lower it is within that subset, the less likely you are to have a heart attack. And so at Harvard, they did a study where everyone got 2 HSCRPs, and they had to correlate with each other before they even looked at it. So if you had 2 HSCRPs that correlated, if your HSCRP was 0 or your HSCRP was 5, that did stratify risk for coronary events to a small degree. If your HSCRP was over 5, it no longer stratified risk. Okay. So only between 0 and 5 does it stratify risk. Well, that is a hard concept for doctors or patients to understand. So you get an HSCRP and it's greater than 10. It's like, oh my God, I'm going to die. No. Oh my God, this no longer stratifies your risk. You have no value in your HSCRP because it's over 10. Only between 0 and 5 does it stratify risk, and it only stratifies a little bit. You had alluded to the MESA heart trial. In the MESA heart trial, the baseline HSCRP of the people who had heart attacks was slightly better than the baseline HSCRP of the people who didn't have heart attacks. So if you look at the MESA heart trial, a randomized prospective, it wasn't randomized, just a prospective observational trial of cardiovascular risk factors, if you looked at that, would say, well, gosh, HSCRP is of no value in screening for cardiovascular risk. And the fact of the matter is, HSCRP is of no value in screening for cardiovascular risk. It does give us some data. Inflammation is part of the picture, but there's so many things that will cause inflammation in our bodies that HSCRP is not it. Unless you do 2 HSCRPs, they have to correlate, and they're between 0 and 5. Then it has a small correlation with cardiovascular risk. Subsequently, Harvard has done additional studies that have shown a value, the asteroid trial, for instance, a value. It did not show a value. It was a contrived value. It was a made-up value. They push it as a value, but if you interrogate the data they're giving us, they show no value in HSCRP as defining risk. HSCRP I will occasionally use in patients who are at high risk with the hopes of getting an HSCRP of 0. If I get an HSCRP of 0, I say, okay, this is good. I think we're on the right track. Let's see what the next calcium score shows. If your HSCRP is 6, you've learned nothing.
Okay.
Anything above 5, it's useless. So a almost useless test that in the circumstance of screening for heart disease is truly useless, has been proven to be useless. And yet, go to Harvard, they'll say, check an HSCRP.
So I can't go to bed at night leaning on my HSCRP to tell me if I'm going to have a premature heart attack or stroke. Who owns the patent on HSCRP?
Rumor has it that Harvard has a financial interest in HSCRP. And I'm kind of hoping that that's not the case. But when you keep hearing the same rumor dozens of times from dozens of different people, you figure it's probably the case.
Okay. So people can own patents on laboratory diagnostics.
People can own patents on laboratory diagnostics, but more importantly, through ways that are not obvious, the researchers can make a ton of money off of doing specific research. And so if I'm doing an intravascular ultrasound study that is not nearly as sensitive as a coronary calcium study, but I can bring $50 million, $100 million to my institution by doing an intravascular ultrasound, actually coronary ultrasound study, then I'm going to do that because that's my shtick, that's my gig. And if I'm making $50 million, $100 million for my institution, I'm making a little bit for myself along the way. I get a little bit of a finder's, almost always. You get a little bit of a sweetener.
Yeah, we both have colleagues who are they live and die by the grants they get and so on and so forth.
I get a little sweetener from that.
And it's complicated. I'm not anti-money and innovation, even in medicine, but when it comes to public health policy and setting standard of care, it needs to be as clean as possible.
So when I'm one of the people that CNN will interview to get my opinion on heart disease, and my opinion is being influenced by money that I am making from ignoring the most valuable technology and pursuing a less valuable technology and undocumented technology. And we haven't proven the value of intravascular ultrasounds in coronary disease and coronary events to the extent that we have with coronary calcium. And it's a hugely expensive, hugely invasive, non-screening test. And yet we're going to have those people say, don't ever do a heart scan because you can do an HSCRP, and if we need to, we can do an intravascular ultrasound. This is crazy talk.
So let's pick on everybody.
All right.
Let's pick on the nutritionists.
Okay.
Body mass index. I'm watching the Widowmaker, and I see a tall, maybe 6'3", handsome Irish billionaire, thin and lanky, looks like he works out, and he's got a calcium score of 900. He has raging heart disease. Can I trust body mass index? If I lose 10 pounds with the nutritionist, does that mean I'm not liable to have a heart attack or stroke?
Mayo Clinic actually did a study looking at body mass index and cause of death. And what they found in their study is that people who were morbidly obese, the 300-pound people, did indeed have the highest risk for a cardiovascular event. The second highest risk were skinny people. Body mass index less than 18, less than 17. So skinny people were right below morbidly obese as far as cardiovascular risk. If you looked at you had skinny, ideal body weight, obese, skinny, ideal body weight, overweight but not obese, obese, and morbidly obese. Of those 5 groups, the group that had the lowest cardiovascular death was overweight but not obese. Ideal body weight and obese tied for second highest cardiovascular death.
Wow.
And it wasn't until you got to skinny or morbidly obese that you saw a substantial increase of cardiovascular death. Did a similar study in Asia, found no penalty for morbid obesity. So in Asia, skinny was far and away the highest risk for cardiovascular death. Now, there are a lot of factors that go into getting skinny. Maybe you're nutritionally deprived, maybe you smoke cigarettes, maybe you have other illnesses.
Maybe you don't sleep well.
Maybe you don't
You're
sleep
strung
well.
out.
But let's get away from this concept that obesity is the number one risk factor. Yeah, there's lots of reasons not to be obese. I need to get skinnier than I am.
Yep.
But that's more for my knees and my hips and my sleep apnea. It's not to keep me from having a heart attack.
Yep. As you know, to finish up round one, I'm a blue collar kid with white collar education opportunities. You have a lot of blue collar background too.
Absolutely.
When I first listened to the peer reviewed data driven talk you gave on coronary calcium scoring, serial calcium scoring. As we say, the most important heart scan, if you have positive calcium, is your second one, right? You need the show me the money test to show me that. And then you look at all the false prophets. Get your first carotid ultrasound, look for plaque here. Get your first EBT or 256 slice if you have it in your neighborhood here, so you can track your plaque. If none of that is available in your area, at least get a 64 slice heart scan they're advertising for $50.
Get
to
something
say,
somewhere, yeah.
I have plaque or I don't. You can, if you do, you can fly into Boulder County. We can set you up with front range imaging. There's some good imaging centers in California. There's some places that are doing progressive arrest this epidemic of heart attack and stroke.
And my position is, let's do this, and let's do this for the cheap. Let's not spend a lot of money doing this.
That's it.
A heart scan is not expensive. A heart scan costs less than an advanced lipid panel by a lot. The heart scan is really inexpensive. Incredibly low radiation dose. How many cardiologists I heard saying, I don't want to get a heart scan because I don't want to give my patients, I don't want to get that kind of radiation, who don't hesitate to do a nuclear stress test that has 7 times the radiation dose. Or an angiogram that has 3.5 times the radiation dose, 4 or 5 times the radiation dose.
0.7 millisieverts on the EBT. It's 4.9 millisieverts to live at a mile high for a year.
Right.
If you can't handle the radiation of your first heart scan, you got to move from Colorado. You got to move down to San Diego.
And the good news with the Siemens 256 dual source scanners, dual row detector scanners, similar radiation dose to the EBT.
Fantastic.
I mean, the EBT not only brought incredible speed, but also brought an incredible radiation dose reduction compared to the scanners that were available and have been available until the current generation of scanners. The current generation of scanners, we've got the radiation dose down to approximate that. And with the Siemens family of dual imaging, dual detector scanners, we've got it down to equal speed, equal radiation dose to what the EBT brought us 42 years ago.
Unreal. We want all colors, all creeds, all genders, all gender identity. What if you are a human being and you are 40 or older as a male, get your first heart scan. 50 or older as a female. If you have major family history, Uncle Frank stroked out on a fishing boat at 44, you can preload that 5 to 10 years. The radiation's so low.
Or if you have major inflammatory disease otherwise.
Yes.
If you have rheumatoid arthritis, Crohn's disease, diabetes, things like that.
Yes.
Maybe get it done 5 or 10 years sooner.
We know the black community on average has lower vitamin D levels. You want to pump that up, hypertension. Everyone needs their first heart scan. The average national cost for this is about $200 to $500. There is one state in the union, they review this on the Widowmaker, Texas, who has insurance coverage because a icon of a congressman gave a darn about his citizens and made sure they took on the interventional cardiologist and got the heart scan paid for via insurance. That should be standard, but we'll get there.
Well, eventually.
Yep. Thanks, Bill, for breaking this down. Next time we hang out, we're going to talk about underlying causes of how did I build that plaque.
All right. Look forward to it.
Thanks again.